right, guys.
Another medication that we're going to talk to with regards to heart failure is Natracor. So it's a direct vasodilator. So where would it work on? What portion? Pipes. Okay. Now the question always is how does our body know when to do all of these things, right? Without pharmacology involved. Like how does our body monitor, or how do we know, how does it know when we have too much fluid and we need to pee more versus less fluid, when we need to keep more, like how does our body do all of this stuff? How does it know when our heart rate needs to go up versus down to compensate for something or not? Like how does our body do all of these things? Besides the million mechanisms that we have. One of them, specific to our cardiac system, is what we refer to with the BNP. It's, I think, beta natriuretic peptide. What this does, what BNP does, is that it, we have our normal, let me try that over here. We have this as our normal, right? This is decreased, okay? And this is increased. And we're referring to the fluid because that's what fills the space. If I have more fluid, it increases, right? Either if it's decreased and I have more fluid, it'll get to normal. If I keep increasing the fluid volume, it becomes increased or more dilated, right? Okay, so the reference is to fluid. Okay. So this would be our normal blood vessel or our normal pipes. When we're diuresing or we give the diuretic, we would expect it to decrease. Okay? If I'm sitting here eating a bunch of chips and chugging a bunch of water after, I'm expecting it to be increased. So when does our body know enough is enough? When our heart or our vessels stretch, there's only so much stretch it's supposed to have, just like if you get a rubber band. It can only stretch so far before after that it starts to tear a little bit, right? You see those micro tears on the outside of the rubber band? And if you continually do it and keep pushing it past its limit, it continues to tear until it actually just rips the whole way through. But if you were to keep it the same way, the same size that it came, is it ever really going to tear? No, right? So if we keep filling it to normal or not past its capacity, all is well. The second that we begin to stretch our blood vessels past where it was meant to stretch, it releases, in this case, it releases BNP. This peptide circulates and ends up telling our body, hey, we've got too much fluid, right? Because that's what's stretching the blood vessel. It says, hey, we have too much fluid, we need to decrease the fluid, therefore decreasing the BNP. So our body normally does that by telling the kidneys, hey, pee it out, but when we've got issues going on and it can't do that, then we have to do it. So big way we do that is by diuretics, allow them to diurese or pee, and that would therefore decrease the BNP, okay? So we can get a direct vasodilator, okay, like it says the BNP, when the ventricles are increased, have that increased stretch, it'll send that out, and it enhances, that's what tells it, please pee, right, and get rid of sodium so that we're not keeping the volume inside. Side effects for this specifically as well is a headache. Does it make sense why you would get a headache? If it vasodilates, we talked a little bit about that last week. If your veins dilate or become larger to decrease the pressure that's in there, does your skull have a lot of play? No, that's what hurts. Right? And then you can also cause dysrhythmias with this. Okay, so it's a direct vasodilator. Don't worry about this one. I'm not gonna put this on the test, so we're gonna skip this one. I think it'll probably just confuse you. But as you can see here, you have what we refer to as a normal heart. You see the muscles, right? The muscles are in the ventricles because that's our pump. We don't really have like a whole lot of that going on in our atria because again, they don't pump. But then a congestive heart failure, look at how much area I have for my stroke volume, how much that's decreased in these patients, right? Do they have a normal stroke volume? Is it decreased or increased? Decreased stroke volume, and that's actually how we end up diagnosing heart failure. Is they get what we refer to as an echocardiogram, so that takes a nice little picture of the heart, an ultrasound, and it lets us know we can literally see how much stroke volume they have. We normally check, and that's referred to as their ejection fraction, or their EF. Ejection fraction. And it's done in a percentage. So normally we want 55% plus, and it can, the highest I've ever seen it, I think, is 70%. You want it greater than 55%. That, again, not all of your fluid that's coming out, that is in your ventricles, is going to come out. Okay, so it's a certain percentage of that. So if we say that the left ventricle has 100 mLs, okay, if it's 55%, then that means 55 mLs are being pumped out, and that's okay. That's fine. But what if out of 100 mLs, I only have 10% or 10 mLs pumping out? Is that a good thing? Am I going to be perfusing for very long? No. How is my body going to try to compensate to get that moving? Increasing the heart rate. Guess what? Is that going to do much for me? Probably just going to throw me into an arrhythmia because what are you going to do with 10 mLs? Right? Can't do anything with that. So the degree of heart failure depends on the ejection fraction. Again, when we have our stroke volume, again, normally it's 40 to 60 of how much is actually being ejected, but it does have the capacity to hold about 100 mLs. But only 40 to 60 ejection fraction wise is what's being pushed out with each stroke. Does that make sense? Okay. So that gives us how bad their congestive heart failure is. We can actually also see this on x-ray. We see an enlarged heart, what we refer to as cardiomegaly, then we know that they're in heart failure as well. Skip this one. I think this is over. This is more, let's do this one next together. So your grandma with heart failure is telling you of her sudden vision changes that include seeing halos. Which of the following medications do you suspect is causing this? Digoxin. So she's having a sign of dig toxicity, right? Which can be potentiated if what lab is high or low? Potassium is high or low? Which one would increase the risk for dig toxicity?
Low.
Low. So if their potassium is low, we give the dig halos. Okay. All right. We talked about this last week, so a lot of this is going to start being reviewed, hopefully. Angina is just the word that we use for chest pain. It's caused, like we talked about last week, decrease of oxygenation to the heart. And it can also be caused by an increased oxygen demand on the heart. So many times if these people are starting to exercise, all of a sudden they get chest pain, they stop exercising, give it a couple minutes, and then they feel fine. And they're like, oh, I feel fine. And they start, and then, well, hold on. Whew, right? You're increasing the demands of oxygen on your heart, and your heart can't do that. So, you can have it when there's decreased oxygenation, such as a clot, right? Or it can be exertional, what we refer to as exertional. When you exert effort, you're trying to do something, you're walking, you do something you normally don't do very often, it increases a higher metabolic demand on your heart, and your heart's like, hey, my pump doesn't work, I can't do that. Okay? So what do we give for that? In the movies. What do we give? Yes, we give nitro. That's, when we say nitro, we're referring to nitroglycerin. Most of the time it is sublingual. You'll see these little white, tiny little white pills. It can be a spray, don't worry about that. We'll focus on sublingual because that's most of the time what you give. Okay. And what it does is that very quickly it causes venous and arterial dilation. So what is it going to do to our pressure? Decrease the pressure, right? Because if we're opening up, if we're making our water hose bigger, the pressure is decreasing. It can decrease the preload and the afterload, right? Decrease the pressure. So it reduces the cardiac output and the workload, which is what we need to do, right? If it was exertional and you're increasing that, you want to decrease the demand, so you do this. But again, if it works too well, it can cause them to pass out because their blood pressure comes down too much. It can give them a headache. Again, you're vasodilating. You're making more space and that the head does not have. So it'll cause a headache. It can cause flushing. And again, decreased BP. You do not want, the biggest question to ask for this, especially because most of the time our older patients are taking this, is what? We all have seen this in movies, fine.
They're taking Viagra.
Viagra. Okay, shout out to Viagra for this one. Viagra, I don't know, did I tell you guys the story of how Viagra came to be? Yeah. So, when they found out, yeah, it was actually for decreasing blood pressure, and they just happened to know that, hey, everything else gets bigger too. So, they got excited, and what happened is because it decreases blood pressure, allows for blood to fill. That's how you get it on. So it allows for the time for filling. So as that happens though, if you're doing this, which is potentiating the effect of the Viagra, increases the headache, increases the low blood pressure, increases your syncopal episodes because you're basically overdosing on the same type of medication. Does that make sense? And this one, once you give it, there's no point of return, right? It works within 1 to 2 minutes.
Well, Jack Nicholson?
Jack Nicholson and what's her face? Right? And he's like, no, have you taken this, sir? Have you taken Viagra? Sir, have you taken Viagra? No, because they're standing right outside and she's young. No. And they're like, okay, we're just saying because you could die if we give you this other medication. Yes! It was so funny. I love that scene. So yeah, we gotta be really careful with that. Really careful with that. Again, guess what? You're seeing all your same medications. We can use it for all this stuff, right? Beta-adrenergic blocker reduces the cardiac workload by slowing the heart rate and reducing the contractility. There's different types of angina. We're not going to get into that in this class. But for stable, just FYI for later, this is the drug of choice. Calcium channel blockers, right? Relax arterial smooth muscle, lowering blood pressure, and decrease the O2 demand on the heart. When it relaxes, that means it dilates. Okay, so dilates the coronary arteries to increase cardiac blood flow, which is what we want, right? Isn't that what's causing the pain, the heart pain? Decrease in the blood vessels or decrease oxygenation of the heart. So we want to increase that. We could do that with a calcium channel blocker. Again, another type of angina we're not going to get into. Okay. So that's angina. Guess what? We can get the same medications. Okay. Biggest one to know for that one that's new is the nitro. Gotta know your nitro. If you're getting that angina, which is blocking off oxygenation to the heart vessels, your coronary arteries, if you don't stop that, this happens. This is a heart attack, myocardial infarction. This happens when you have complete occlusion of the coronary artery. Like we talked about last week with Lipitor and your lipids and all that cholesterol things. Plaque that's exposed activates that clot cascade like you guys saw in that video. Once it starts, guess what? Everything else will just gimme, 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 gimme. It can end up blocking the entire artery, which it ends up being a plaque. And it blocks that blood flow, right? If it blocks blood flow, is anything after that being perfused? Nope. Good luck on getting that muscle back. Death of tissue or necrosis happens within 20 minutes. How long will it take you if you dropped in the middle of your kitchen and someone was there to watch you and freaked out and then called 911 and then you waited for them to come and then they got there and then you had to go to the hospital? More than 20 minutes? Yeah. Best place to drop dead is at the hospital. Okay, best place to drop dead. So death of tissue happens very quickly. Once it dies, really no chance at regaining that. Okay, they're trying to do studies and things like that right now, but we're not there yet. So your goals for the MI is to either remove the clot if that's what's causing it, to restore blood flow. You want to obviously relieve the pain, but guess what? You don't get no blood flow, pain just stays there. You'll control the dysrhythmias. That'll be a big thing too. I'll get to that in a second. Reduce the heart's oxygen demand. So do we want them going and running a mile after? Yeah. We obviously want to reduce the mortality, right? And prevent any enlargement or prevent any future thrombosis, and that's why we will give NSAIDs, children's aspirin, long term. What do our NSAIDs do? Decrease what? Decrease coagulation. It decreases platelet aggregation. It decreases platelet aggregation. So we give it in lower doses. It's normally 81 milligrams daily. Okay. And they'll be on it for the rest of their lives. So this gives you kind of the same idea from last week with the video. The plaque ends up building up, and specifically for angina or a myocardial infarction, it's within the coronary arteries of the heart. We're not referring to other areas of the body right now. It blocks the flow and oxygenation. They go hand in hand. And this is the damage. Depending on where it's happening, will depend on what part of the heart is damaged, right? So if this is the right side and this is the left side, would you rather have it on the right or the left? Right. You would prefer to have it on the right, right? Why? It's not going to circulate to your body. Goodbye. That's a massive heart attack. People don't come back from those, right? So if you have it in what we refer to as the left anterior descending coronary artery, or your LED, we know that as the widowmaker. Okay? If you have a clot here, guess what? Doesn't get perfused. Left ventricle, goodbye to you. Your pump is no longer with us, right? You lose your pump, you lose everything else. If it happens on the right side, still sucks, but not as bad as the left, right? Would you rather have it higher or lower?
Lower.
Lower. If I have it right down here, is it going to make the biggest difference in my pump? No. So will my pump still work? Yeah. It might have a couple issues, but we can still work with a happy pump, right? So it all depends on where it's at. How we determine where it's at, one is through a cardiac cath lab. Last week we saw that video where they feed the wire through, right? And they did a little balloon pump in the stent. That's in cardiac cath lab. But the first thing that we do on anybody is what?
EKG.
EKG. Nowadays, someone got really smart, and we always did a left-sided EKG. We do all these leads, and we do it on the left side. Someone said, hey, if we flip it, guess what? You get the reading of the right side. Right? I was like, why didn't I think of that? And I think that happened 2 years ago. So now there is a right-sided and a left-sided EKG that gives you a views of the electrical conduction system of your heart. which is cool. So we can tell if you've had different types of issues or clots in your heart, depending on what the EKG reading is. And we can also tell whether it's inferior, superior, right or left, and the ventricle versus the atrium, things like that. And they have to do a 12-lead EKG for that. So if it is due to a thrombus or a plaque or something that breaks off, the first thing we give is what's referred to as TPA. Okay, it's alteplase. It'll be on another slide. It's referred to as alteplase. They do the streptokinase, but in our area they use TPA right now for everything. There's a lot of things that criteria you have to meet in order to receive that treatment. What it does, think about what you think it would do. I have a big clot and it's stuck somewhere and it's not allowing perfusion to anything past that. What would I want my medication to do? Break the clot. Right? I want it to break the clot. And that's what TPA is. It's what we refer to as a thrombolytic. Lytic means to kill, get rid of. Okay, that thrombus. And that's what's straight. It goes everywhere. Does it go straight to the clot and say, hey, I got the clot, we'll just work here? No. So what is it doing really? When you say breaking the clot or get rid of the clot, what's it actually doing?
Killing the clotting factors.
Breaking it up and getting rid of the clotting factors, which push me at risk for bleeding. Woo-wee. You thought NSAIDs were bad? This is like the mother of all NSAIDs. Okay? Literally, the second that we give it, you could bleed out. So if you've already had a surgery, if you have an open wound, if you have anything like that, guess what? You're not getting this. Because the second we do that, it's just going to literally just bleed out because it's breaking all those clots that you've already formed. So you have to be intact. After this patient receives this, there's no poking, not even for labs, nothing, because they're not going to clot. If they have a brain bleed, you don't get this. Because the second you give it, goodbye. You have to make sure their pressures are lower within normal, because guess what? If their pressures are really, really high and I give this to them, what's gonna happen? What are the risks for that?
Ruptures.
Ruptures, and are they gonna be able to clot? No. So it's a very, very serious. We only have very little time limit, about 3 to 3.5 hours, to give this medication from the time that someone saw them having symptoms. If not, you miss the opportunity to receive it. Okay, so narrow margin of safety. Major thing with this is bleeding precautions all the way. Literally, we don't even poke them. We put in a Foley before we even start this, because I've seen it when someone does it, and you have to put a Foley because they haven't urinated while they've been on this for 24 hours, and this blood starts coming out through the catheter. So not good.
So a diabetic would not qualify for this?
Oh yeah.
Then how would you do the active checks if they don't listen?
No, so if they did need something like that, then we would put in any lines that they need before that. So we could put a central line in for them, or we can do like our arterial line, so we can just pull from there. And this patient always has to have 2 IVs before we even start this. Because after you do that, you lose your IV, good job, like you can't poke and prod for another one. So any lines, anything that's invasive, so it's a very busy patient that you'll have if you're gonna do this. And it's a 1-to-1, just wonders to that patient because there's so much involved. But we do have that first line treatment now for patients like that.
How long does TPA take to get in one?
We give it IV, so it's instant.
Oh, okay.
Yeah.
And then however long we run it for?
We run it for an hour, and that's it. And then we can't do any new lab for a minimum of 24 hours. Yeah.
If they start bleeding, then what do you do?
Literally apply digital pressure all day long. We have sandbags, depending on where they're bleeding or why they're bleeding and stuff like that. If it's from, maybe they took something out or they got a scrape or something like that, we could put sandbags on them, just pressure. pressure all day long. We're constantly monitoring, they're in the ICU, we're constantly monitoring their heart rate, their blood pressure, all of that, because again, those things can fluctuate depending on if they're have enough fluid as well. We can tell if they're bleeding out. We'll monitor neurological status too, because if they're having a brain bleed, they'll have stroke-like symptoms as well. They'll start being confused where they weren't confused before, so we'll run them down to CT, and then most of the time they'll confirm a bleed or whatnot. So we either stop it or we have to try to give something to counteract it, but then we put them at increased risk for blood clots, right? So it's intense to get some of these patients, especially when it's a grandma and you're like, really? Oh my God, I'm supposed to do a grandma right now. So it's 1-to-1 for 8 hours, for 8 hours when you have these patients. But it's very effective if it actually works. It's very, very effective. The only problem is you got a lot of risks versus benefits many times. So, as soon as the patient starts having MI or is suspected of having an MI, the very first thing we do is say, here, have an aspirin. We give them the kids' chewables, the 81 milligrams, say, suck on this please, and we will continue on our way. That's always number one. An alternative to aspirin would be an antiplatelet as well, which is Plavix. They're interchangeable. Some people have an aspirin allergy, so we can give them Plavix. After that, in the hospital, they'll be on an anticoagulant. So this is kind of the middleman between this crazy guy over here and these. So you've probably heard of heparin, naturally found within our bodies anyways. So we can use heparin. Lovenox is just a low molecular weight heparin. Coumadin is a PO form that they'll go home on. Okay? So this one they'll go home on. What's the risk of taking any of these? Bleeding. 50% susceptible to bleeding. It is normal, heparin and Lovenox we give as injections, sub-Q injections. It is normal for you to have a bruised area around it, right? For it to be absorbed. It's causing that locally. So that'll be normal to see. Coumadin, you'll go home on it. When you go home on it, you still take labs, I believe weekly, to check to make sure that they're within normal range. This you'll never go home on. If you do, you're suicidal. That's very, very strict. Okay, so first thing, I suspect an MI, I'm going to give you no matter what. 81 milligrams, children's chewables is what they'll call it. Okay, number one. I have an allergy to aspirin, I'm going to give you Plavix. Those are both antiplatelet. So I'll give you Plavix and just let you know it's also an antiplatelet. Right? While you have your hospital stay, I will give you either heparin or Lovenox. Okay? Those are by subcutaneous injections, so anywhere you can pinch an inch, you have a little bit of fat, you could throw it in there. Normal side effects of that is going to be that you're going to have some bruising at the injection sites. If you need to go home on it, you'll take Coumadin. When you take Coumadin, you still teach the patient to monitor for what? Bleeding. Signs and symptoms of bleeding. Okay? Now, Coumadin decreases the availability of vitamin K. Vitamin K allows you to clot. Okay? Vitamin K allows you to clot. It helps you clot. So would it make sense for us to stop that ability in order for you not to clot? And the problem with these patients is that they had a clot. So we want to say, hey, can you slow down? So we'll give you something to decrease the vitamin K so you don't clot, right? So that's what Coumadin is doing. So it decreases blood clotting factors, therefore decreasing the formation of blood clots, but it prolongs bleeding time. So again, signs and symptoms we're looking for? Bleeding. There are therapeutic levels in labs that we take, and these we take on everybody who walks through the door, INR, PTT, and APTT. Don't worry about memorizing those. Who likes Calvin Klein? Nobody? Come on, who likes Calvin Klein? Even if you can't afford it, who likes Calvin Klein? Everyone's like, okay. Okay, that's how you remember this. CK. When you give Coumadin, it's antidote is vitamin K. Okay? Yeah, because if it's stopping the vitamin K, if it's not allowing you to clot, you give the vitamin K, guess what? You clot. So when they're taking Coumadin, we're telling them to avoid foods that are high in vitamin K, which are green leafy vegetables, believe it or not. If we want to counteract that, we say, please eat it, right? Eat your salad, eat your kale, eat all that stuff. Again, bleeding precautions is the biggest thing. Now, question. So we have TPA, which is a thrombolytic. We have like Coumadin, heparin, Lovenox. Okay. Does my Coumadin break down the clot? It prevents it from clotting. So if I come in with a clot and I start taking like heparin or Coumadin, is it going to help with the clot that I have? No. What is it going to help with?
Future clots.
To get any clot. Because once I have one clot, guess what? I'm at risk for more clots. So it's reducing the risk for those. So that's why we would give a thrombolytic in order to break up the initial clot. And then long term, to decrease that, we always give what first? Aspirin, but I'm allergic. Plavix, great. While in the hospital, I'm getting heparin or Lovenox, sub-Q, and then I'm gonna go home with Coumadin, right? Coumadin, what is the antidote? What do I tell them when they're taking Coumadin? Don't eat a lot of green leafy vegetables. Perfect. Okay. The names, other names for the anticoagulants are Xarelto. You guys have probably heard of that. There's a lot of commercials for that. Xarelto and Pradaxa. That's a little bit newer, but Xarelto is like the biggest thing. I think that dude on Dancing with the Stars, or no, the Jillian guy, the workout dude, he's on there for Xarelto. See, you worked out and everything. Don't voice so loud like that. So heparin, naturally found in the liver and lining of blood vessels. It is not absorbed well in the GI system, so that's why we either give it IV or we give it sub-Q. IV would only be in intense cases when they have like a PE, a pulmonary embolus, we'll give heparin IV. It's what we refer to as a high alert medication. If you guys remember way back when in the first week, we talked about high alert medications. So those are the ones we want double verified with nurses to make sure you're not giving the wrong dosage. This is the one that, what the heck was his name? The one that was married to Meg Ryan. What's his name? Dan or something? The actor. Y'all know who Meg Ryan is?
Yes.
You know the ex-husband, right? She was with for forever. The guy who did Rookie. Oh, what's his name? You guys know his.
He's in commercials now.
He's in commercials now. Yeah, he's
He's so old. Dennis Quaid.
Dennis Quaid. Well, with his new wife, he has the twins, right? Over at, I think he was at Keck or UCLA. I forgot which one he was. And his kids almost died. His twins almost died. Nurse made a medical error and gave too much heparin, so they almost bled out to death. Both twins. High alert medication. Double check with somebody else, please. And make sure when you're doing it, please make sure double check. Don't be like, oh yeah, really, you're a good girl, and walk away. Because guess what? You have to put your name in for that double verification. So who else is getting in trouble? You. So that is what we refer to as a high alert medication, especially with kids. Onset is 30 to 60 minutes. Peak is 2 hours. We draw what the lab is an APTT. It's a thrombin time, right? Thrombin time. To check its effectiveness. We can get a side effect referred to as heparin-induced thrombocytopenia, known as HIT. Who wants to drink that? Okay, so remember when she was pregnant? No, you know, all the lights went out and all that craziness. Oh, that was so good. So she got pregnant, right? And then she ended up, I forgot what happened. She ended up getting heparin, didn't she? I think she ended up getting heparin. Oh, but she ended up going into DIC, right? So where it's just bleed out like crazy. that's what this could cause, heparin-induced thrombocytopenia. So you end up basically throwing a bunch of clots to where you can't point clots anymore, and then you don't clot anymore, and then you bleed out. Yeah, that's right. So not a good thing to have. If that starts to happen to your patient, they just put you on a different thrombolytic. But they'll first give you what?
Aspirin.
Vitamin K, right? To reduce, heparin. Don't worry about this side over here. Again, thrombolytics, just the same thing. TPA or activase, alteplase, I don't care what you call it. Side effect is hemorrhage. These patients are in ICU. We monitor their blood pressure and clotting, bleeding precautions. Biggest thing we do, like I said, is neuro, because we want to know if they're bleeding intracranially. So we're always checking their neurological status, like literally every 10 to 15 minutes. What's your name? Where are you? What's your date of birth? What happened when you came in? They hate us by the end of like an hour.
So what happened to a mom who has a clot and is pregnant?
Depends where the clot's at. And it also depends, because that has happened. It depends. If it happens on the placenta, right? And it's causing something, an issue with baby where they're not oxygenating, depending on how many weeks they need to get the baby out there, most likely. If it's happening just to mom, then they can put them on drips to try to reduce it. But they're just gonna really heavily monitor her and monitor baby.
Is that one of those medications that causes the full cycle?
I believe so. So they get a lot of ultrasounds, because again, the placenta can bleed up too, or it can start having abruption, when the placenta pulls off early, and that causes bleeding inside, so not a good thing, not a good thing. This is like our last big flexor before we say we can't do anything for you. Last week we talked about Epigen, right? When we talked about our kidneys, they release erythropoietin, which increases our red blood cell production. If we have red blood cells, we can oxygenate adequately, right? Neupogen, neutrophils, means white blood cells. So Neupogen we can give to increase our white blood cells. Don't worry about this down here, but yes, we can give you something to increase your platelet production if you're having an issue with that. So Epigen we covered last week. I just want you to kind of understand that this, I'm not going to test you on. Neupogen is just neutrophils, white blood cells. I'm not going to get into the mechanisms for this. Okay. Who has questions? Whose brain is about to explode? Question or explosion?
Explosion.
That's okay. Okay. Take a 10-minute break, and then we're gonna come back and talk about EKG. Sometimes they do, sometimes they don't. But they have had one before. So the rest of this is gonna be FYI information. It's not gonna be on your exam really, I don't think. I'm not gonna go into detail about shock. It is very advanced. This will be more ER ICU than ICU all the way. This is mostly what we deal with, but it does correlate to the cardiac output idea that we've been talking about since the beginning of class. So when we talk about shock, what we're referring to and what we're worried about is perfusion. Okay, that's all we're worried about, is perfusion. When you are in a state of shock, your perfusion is decreased. For example, there's 1,000 different types of shock. We have cardiogenic, neurogenic, hypovolemic, blah, 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 septic, anaphylactic shock. Everyone's more familiar with anaphylactic shock, right? What happens in shock, period, is whatever the cause is, what's going on is that we're decreasing our perfusion. How does that happen? It is a decrease in blood pressure, If we don't have enough pressure in our tube, can it go past and move our pump forward? No, right? Because our blood pressure is low, what's our heart gonna do to compensate for that? Increased heart rate. Okay? When we see this, our patient is in shock. And when I say decreased BP, we're looking at a systolic blood pressure less than 90 or a mean arterial pressure of less than 65. Our heart rate is just greater than 100, because that's normal, right? So when we see decreased blood pressure, increased heart rate, and we've got something else going on, we know our patient is in shock. Our body's already trying to compensate for that shock on the body. So when that happens, our whole cardiovascular system, its number one job is to do what? Huh? To perfuse all of your organs, right? Every last tissue, every last cell in your body, every last end organ, it needs to perfuse that. It needs to pick up any waste that it's generated. It needs to drop off nutrients of whatever. It needs to drop off building blocks to increase whatever cells and things that it's regenerating. We have to be perfused. Hold your breath for more than 10 seconds and see how great you feel. Right? No perfusion really going on. Right? In just 10 seconds, you have that much buildup of waste and that much oxygen that's not going into your body and does not make you feel good. Imagine this process happening very quickly. Someone gets stabbed and they're bleeding out. What's happening with your cardiovascular system? What's happening with the volume? Dropping. So what's our body going to do? It's going to send the sympathetic nervous system response, send out some epi, which does what to our pipes? Vasoconstricts it in order to increase pressure and then increase heart rate. Right? We're trying to, these are compensation methods for something going very wrong. Something going very wrong. That's all that shock is. Now what happens with this if we don't get it under control very quickly? Okay. Things are not being perfused. First things that our body's going to do is say, hey, there's not enough fluid or there's something's going on, you're bleeding out. It vasoconstricts to do what with the blood? Keep it and shunt it where? Shunt.
Your trunk.
Huh?
Your vital organ.
Your vital organs. Because again, if at least our vital organs are perfused, we have a chance of survival. I can live without a leg, maybe two. I can live without two arms. But everything else can't quite live without, right? So brain, heart, lungs, and kidneys, right? That's what it's trying to keep perfused. GI system, remember back to that sympathetic nervous system, that comes to a halt, right? Because we're like, do we need to, digest all this stuff right now? No, I need to get out of this emergency situation. But if we don't fix this emergency situation, depending on what it is, we lose perfusion to all of our organs eventually, and we die. These are emergencies. That's the picture. Gotta get on it fast. Think of anaphylactic shock, just a little that you know from it. Within minutes, the patient can die. Minutes. With all of the other ones, they can die as quickly, but sometimes it takes a little bit longer. The biggest thing, and I want to say this month or last month, I think, was Sepsis Awareness Month. Anybody who gets an infection, you're at risk for sepsis. That's what's killing a lot of people right now. Sepsis, like a lot. Okay, so the second that you start having that decrease in pressure, you start getting dizzy, You start getting lightheaded, those are signs and symptoms of decreased blood pressure. You feel your heart's pounding or coming out of your chest, you start to sweat, right? Sympathetic nervous response. Those are signs of shock, if you have something underlying behind that, okay? The first thing that we do, what do you think would be, just overall, not looking at the different types, because each one has its own treatment, but looking at this, how can I pharmacologically compensate for this? How can I get you out of a state of shock? How do I do that? How do I increase your blood pressure? Increase fluids, right? So treatment. Number one, replace fluids. What fluids do I want to give?
Normal saline.
Normal saline for the most part. I would do blood if my patient's bleeding out, right? Then I replace it with blood. Fluids. Most of the time we do an isotonic solution, so that's normally our NS. So that'll help increase the blood pressure. What else?
Antidiuretics.
You can, if this is a long-term issue, then you can give like ADH. Absolutely. What else?
You're just trying to like.
Immediate, like right now, it's gonna work right now.
Epi?
You can give epi, but
Heart rate's really high.
yeah.
So are you trying to fix the blood pressure or are you trying to drop the heart rate?
Trying to fix both.
So something like a downer?
Well, but think about it. If I fix my blood pressure, will my heart rate come down? Because my heart rate's only compensating for the decrease in blood pressure, right?
Vasopressin?
Who said that? We give what?
Vasopressin?
Yes. We give vasopressors. Something that's going to constrict. Epi could be one of them, but it's definitely not our first one, especially if their heart rate is already high. But we give things like Levophed, we give things like neosynephrine. I think we talked about, that was the one that you can also inhale to reduce the rhinitis, right? Again, because it vasopresses. So this is our first line treatment right now. That should take care of the heart rate. It should bring it down to normal levels. Because the reason the heart rate is fast is because we are decreased on fluid. So if it's not circulating, our body wants to compensate and say circulate faster, so we still have perfusion to these organs. So the second we fill it with fluids and we say here's more pressure, our heart rate's like, okay, yeah, it's not under control. That's what's supposed to happen. This is the basis of shock. You're worried about perfusion. Are your organs perfusing? If your organs are not perfusing, we end up having organ shutdown or organ failure. So if you've ever had anyone or heard of anyone that's had that in the hospital, like, oh, they're having organ failure, full body organ failure, it's because they've been in shock. Okay? That's all I'm going to talk about with that. And this is what you can see. You get a lot of issues. Again, you start having renal failure, GI failure, lung failure, heart failure, failure all over. This bad boy is something that you're really going to want to hold on to when you guys go into your nursing program, especially if those, I think after you guys wanted to do like ICU, ER, flight, you know, all the adrenaline pumping stuff, this is something you're going to have to memorize left and right. So I would definitely keep this chart. Now EKG, when we take it, it's full of things that look like this, hopefully, that are somewhat normal. Anatomy physio, who can name that part? So, what's this part? P-wave? Okay. T, right? Anyone knows our ABCs? Okay. P, Q, R, S, T. Now what does each one represent? What's our P wave?
And do the nose, right? Like the electric.
Yeah, it can, yes. Well, what's P wave? Yes. P wave is your atrial depolarization. And what's your QRS?
Ventricle repolarization or depolarization? Depolarization.
Ventricle. Who says depolarization? No one.
Wait,
Who
which one?
says it's either depolarization or repolarization?
QRS?
QRS.
It's depolarization.
Repolarization.
So who's going with depolarization? Who's going for repolarization? Everyone else don't know what to do.
I don't know.
So it is depolarization.
More depolarization?
And what is your T wave?
Ventricle repolarization.
Ventricular.
Repolarization.
Now, where the hell is the atrial repolarization?
Right before QRS, or like right in between, but it's so small.
It's happening in here, but no one cares because that's what does big QRS. So it's overshadowed by it, okay? So this is what's happening. We have our heart, we have our, right? Our love dub. What is our love? What is our dub? What's making that noise?
The valves.
Well, which valves? You got 4.
See the atriums or the ventricles both?
Well, which one you tell me?
So the love is the atriums pushing, I think, into the ventricles. The dub, I think, is the ventricles.
Thank you.
Does everyone agree with that?
Sounds good.
Right? Are they happening at the same time, or is the right going first and then the left?
It's top and bottom.
Yes. So both atrias are going at the same time, both ventricles are going at the same time. Okay? So it's love done. Does that make sense? Okay. You can't have one side because then the pump doesn't circulate, right? It's got to happen at the same time. It's a closed system. So we have our. When we hear that, what's happening here is, okay? So we have our, this is our love, and this is our love. Okay. How do we picture it? So we hear it. We see it on the EKGs. Does that make sense? Okay. Because again, atrial depolarization, atria, love. QRS is our ventricular depolarization, right? That's our dub. This doesn't make any noise. We won't go there today. So this is what we're looking at. The repolarization just means that stuff's going back to where it started in the first place to be able to cause a contraction again. That's all it's doing. We're regrouping. So that doesn't make any contraction. That doesn't make any noise. Now, with this is what we should normally see. We should see one P wave, one QRS complex, one T wave. There's 1,000 different variations to this of what's happening in your heart. Okay? Again, depending on what you see on the EKG, can tell you a lot about what portion of the heart is being affected, and then you can also derive what signs and symptoms you would see based on that EKG. Because you're looking, in a 12 lead, you're looking at things that are very specific to particular locations. Okay? But I want you guys to really understand what the EKG represents. Normal sinus rhythm means that you see this on one 6-second strip, anywhere from 6 to 10 times, right? 60 to 100 is normal. If you see this, but it's only 5 times on a 6-second strip, what's happening with the patient? They're bradycardic, right? If you see this same thing, but you see it 12 times on a 6-second strip, which means 120 a minute, they're tachycardic, okay? So that's what's happening here. You don't have to worry about the segments. No one, unless you start going into really cardiac stuff, you'll see that stuff. Okay, I'm not gonna teach you guys EKGs. I don't think anyone cares to know right now. So, I'm not gonna go into that, but do realize that your sodium and potassium as well as calcium channel blockers will affect your EKG. If it affects the electrical conduction system, like digoxin, how is that gonna affect your EKG? What did digoxin do? Lowered your heart rate. So I have a 6-second strip. Let's say I have a 6-second strip, okay? And I see my QRS is how many beats is that per minute? Let's just say this is, I'm not gonna draw all that. You know, this is 80, right? So 1, 2, 3, 4, 5, 6, 7, 8. This is 80 beats per minute. Because we draw them out on 6-second strips. How many, this is 6 seconds? 6 times 10, right, is 60 seconds. Gives me my beats per minute. So anything right here, I multiply it by 10, I get my beats per minute. Does that make sense? So now let's say I have this, and I have, what's my rate? 40. Okay. Say I have, how many do I have now? 140 beats per minute. Okay? So it can be a lot. It can be a lot. But just know, so what is happening when you see this? What's happening? Your heart. It's overworking. It's not. It's. You're like, okay, right? But when you have it low, it's. Right? So know what's happening in your heart when you're hearing these things, and start seeing how you're correlating all of this stuff. Because what students end up doing is that they say, oh, the EKG is XYZ, and they learn all this stuff for the EKG. And then they say, oh, pathophysiology, I'm learning all this stuff with pathophysiology. Oh, my strip, I'm learning all this stuff with my strips and what they all mean and blah, blah, blah. And then you're not correlating all 3 of these and how they fit into each other. Does that make sense? They're all showing you the same thing in different ways. Does that make sense or not really? Okay? Because that's the biggest thing I see with students, and I was just out with 2 students that just got both their dream jobs last Friday. And that was the biggest thing they said. They were like, oh my God, when you forced us to show the correlation of all of this stuff, like everything made sense, and that's why I got hired in the ICU, because they asked me a question, I remembered what you said. And I showed them everything, and they were like, that even his educator at Pomona Valley, the educator was like, how could you be asking such high-level questions for a new grad nurse? And so that's the thing, is you've got to go back, you've got to correlate all this stuff, and what does it mean? How does it work, and what does that mean to me? What signs and symptoms am I gonna see in this patient? What would I expect, and what would I do, right? What am I expecting to do? How would I educate them? That's how your mind needs to get out of that box of just checking off boxes and memorizing stuff and really understanding what's happening. Because all nursing questions are is just giving you a different patient scenario. That's all it is. If you really understand it, just like what I showed before with the, going through the heart, right, a drop of blood. If you have right-sided or left-sided, you gotta, don't try to memorize, like, oh, right side is blah, 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 blah. Understand what is happening in the body. So the second you understand it, you can walk yourself through what's actually happening with the patient and what you're expecting for signs and symptoms and how you would treat it. And that you know that if you flipped it, you'd be like, no, that can't be it because that's not happening, because you understand the underlying pathophysiology of what's happening. Does that make sense? Okay. I was telling a couple people even last week, the first thing I used to do with my quizzes would be to basically memory dump. So I would draw these, like, first day, everyone else just wants to hurry up with time. And I would literally turn over my exam and dump everything that I knew really quickly. I draw pictures of like things like this, and I draw, okay, this is my normal, I know this, I know that. My cardiac output equals SV times HR, you know, whatever my meds are and what they did, or what I knew the side effects were, just jotting down real fast, memory dump. That way when I came across something like that on the exam, they're meant to deter you, they're meant to screw you up. That's what questions are for, right? And so they want to see, oh, do you know the right answer? Can you think about it? I would turn it around and say, okay, so if it stopped right here, then it would blah, blah, blah. What happens when you don't memory dump on an exam?
It's like you
You start
guys
making stuff up. That sounds good. Let me go with that one. But you're not thinking yourself through it, or it's already giving you so many scenarios and so many possibilities that everything starts to just jumble together. So it gives you a baseline to work with. For this exam, I am making it obviously a little bit easier, but it's very intense because the cardiac system is no joke. There's a lot of information, there's a lot of medications, how they work, what you need to know about them, all that. So I highly suggest that you get into a model of some sort to be able to memory dump on the back of your exam and draw pictures or write your mnemonics or dish toxicity. I would put like low potassium equals increased ditch, high means no ditch, you know, like easy stuff that to remember to give me the highlights. And then when I would go through it, I'd be like, what's my baseline? What do I know is fact? Okay, then you would draw from there instead of having it kind of screw you up or give you alternate possibilities and then, you know, deter you that way. So just make sure you guys are, when you guys are studying, as hard as it is, it's easier to get some of this out of the way now than trying to make up for it when you're in the nursing program. And then you're trying to just play catch up and you're going over way more information than even all of this. That's a lot more meds, a lot thicker subject matter. You want to make sure that you have a good, you know, underlying base for it. Okay? Any questions on this?
So every QRS is just a pulse, right?
Yes.
Okay.
When the pulse that you feel is your left ventricle.
So when, like you were saying, that's 6 seconds straight, every QRS, that's one of the beats that we have, and we multiply that by 10 to get a beat per minute.
But it should be your atria, right? Because that's got to go first. So your atria, then your ventricles, and then the repolarization just happens for the atria in between that. Because you have to remember, this is the electrical conductivity of the heart. So what we're really doing is if you look at an actual strip, it'll have like all these little lines, it'll have all these boxes. And each box going up is having to do with millivolts, or what the actual conduction part is. This part is spaced out by time. So it wants to see a correlation between time and like the electrical conduction system of what your heart is doing. Okay? Because there's some that could be literally, instead of being like this, like, you know? And so this is not beating as hard as this is, right? But there's others that could be like this and be like, whoa, whoa, you know, you're like, whoa, whoa, that bad boy's beating really hard. So it lets us know according to that. But your EKG is showing you the electrical conduction of your heart. An echo would be structural, an echocardiogram would be a structural as well as volume, because this won't tell you anything about volume. This just gives you obviously the anatomy and physio of what's actually going on. Okay, and then this as well will tell you your rate and a couple other things of what's happening on the 12 week. So just make sure you're starting to correlate what everything means. Okay, so if I give you a strip and said, okay, this is your patient right now, and their blood pressure, say I give you a strip like this, and I say BP is 80 over 40. What's the first thing you're thinking? Shock. So my patient is in shock. Do I even have to go see the patient to know that they're in shock? Heck no, I'm like, oh Lord have mercy. We gotta get what into this person? Fluids?
Invasive pressures.
Invasive pressures. Let's get it in now, right? So those are the things that as a nurse, you'll start to learn and pick up on. You'll get reported and say, oh my God, we need this, that, and you create your to-do list. Then you go check your patient. Okay? So I am sure you guys will have a lot of questions. I am gonna post these up on, takes forever, by the way.
Yeah.
Oh my God, I was like, I'm gonna be here till next week posting these videos. So I am gonna post them up for you. Everything we've gone over the past 2 weeks, make sure you go over the only thing you're gonna be responsible for is what is on your exam study guide. I will add the couple of medications for this week that you'll have, which I think are just nitro and digoxin.
Yeah.
I think that's it. I'm not gonna touch you on any of the other ones. Most of it was last week that also plays into this week. It will be due, now it's gonna be, no, we don't have a test. So it'll be due before, by next Tuesday night, your extra credit for the med sheets. It'll be due by next Tuesday night, okay? That way I can release the final one just for the cardiac meds. It'll be the final one for you, for you guys to be able to study from for the exam for the following week. This next week is when everyone's presentations are due. Okay, all the presentations are due next week. So you guys should be already in the midst of working on a PowerPoint or whatever your flow is going to be. Make sure you get with the people in your group. If you are having any problem with somebody in your group, just text me or email me and let me know and we'll get it figured out. But I think everyone's been okayed already by me. I don't think there's been any issues, right? So next week we'll have that. I am going to post a discussion board, a separate discussion board for the order of presentations for next week. We will have at least 3 people coming to view the presentations on Wednesday, possibly more, but I know for sure at least 3. 2 are my kids, 1's my husband. He's like, I want to see what they're going to see. So you are going to see that. They will be here to view that, and then so the discussion board will be on who wants to go first, who wants to go second. Please be cognizant of your rubric in order to get your full points. All 2 or 3 members have got to participate. It needs to be within 5 to 10 minutes. Okay, so I know some people are putting videos, some people are doing different things. Make sure that you guys are practicing it to be at least 5 minutes, less than 10, because with 10 or so groups, that's going to be a good amount. Okay? No? Oh, I thought you were like halfway there.
Oh, yeah.
Oh, you are?
I should grant if we go first, right? Like volunteer for first? Like, fully
No,
first?
That's not fair.
We're all, okay, ready? Okay. I'll give it to the first 2 people. You only one representative from the group can raise their hand. So figure out your representative. Everyone make eye contact with the other people. Okay, ready? Who runs up here the fastest? He's like, actually, On the discussion board, whoever answers, the first 2 people to answer, I will give it to them. If you follow directions. 1 representative from your group will be responsible for going on the discussion board and saying, we go first, second, third. I'm gonna put slots on there.
And what time are you posting that discussion?
I'm not sure, so you're gonna have to be on No, it will be during business hours. Probably tomorrow morning. Probably sometime tomorrow morning. So, So I'll get back to Carrie for whoever the first two are that go on there. Since you don't want to run. Oh, I'm just kidding. If you have any questions, again, email, text, I respond very quickly by text. Email or text. I already did your exam today, guys. So it's just presentations and everything. Please make sure you can email it to me if it's a visual, so I can have it before and just have it ready for you. Or you can have it on a flash drive, just know it's gonna take a second to load it up. Okay?
For presentation and exam. Oh, that's not next week, sorry. I double checked.
The exam is falling.
It's the following.
Oh, okay.
It's a real call next Wednesday.